It's my pleasure to welcome Dr. Liana Apostolova to the Oxford Brain Diagnostics guest speaker series. Dr. Apostolova is a distinguished professor in neurology at the Indiana University School of Medicine and the Barbara and Pierre Baekgaard Professor of Alzheimer's Disease Research. She studied originally at the Medical University of Sofia in Bulgaria, completed a neurology residency at the University of Iowa and a dementia fellowship at UCLA. Her research focuses on early onset Alzheimer's disease, and she's the lead principal investigator of the LEADS study, the National Longitudinal Early-Onset AD Study. She also directs the clinical core of the Alzheimer's Disease Center at Indiana University. Now, these talks are usually hosted by our CEO, Stephen Chance. Unfortunately, Stephen's just come down with COVID and isn't well enough to join. I'll say just a few words on his behalf. I'm Jed Ridgway, the Chief Scientific Officer at Oxford Brain Diagnostics. OBD was founded by Stephen and Professor Mark Jenkinson as a spin-out from the University of Oxford. Stephen's background is in neuropathology, and Mark is one of the original developers of the well-known FIMRIB software library, FSL. They brought their expertise together to develop an approach called cortical disarray measurement that uses diffusion MRI to measure in vivo properties related to the mini-columnar architecture of the cortex that Stephen had been studying in the post-mortem brain. CDM was proven useful in multiple neurodegenerative diseases, including Alzheimer's disease, which is the focus of our first product with breakthrough device designation from the FDA. And Alzheimer's disease is also the topic of our talk today, and more specifically, anti-amyloid antibody therapies in Alzheimer's disease. So thank you very much for joining us and talking about that, Dr. Apostolova.
I'm Liana Apostolova. I'm Distinguished Professor in Neurology and Barbara and Pierre Baekgaard Professor of Alzheimer's Disease Research at Indiana School, the University School of Medicine. So thinking about potential treatments for Alzheimer's disease is a really broad concept. We haven't had much success developing disease-modifying therapies whatsoever until only recently, where with some controversy, we have an agent approved. But the landscape is humongous and complicated. Today, we will talk only about one agent from this wonderful graph, which appears yearly in an article review by Dr. Jeffrey Cummings in TRCI. So the top portion here in green is the disease-modifying biologics. In purple are disease-modifying small molecules, and in orange are symptom-reducing small molecules. We would be focusing today on disease-modifying biologics and only on one of these drugs, Aducanumab, which is currently undergoing additional clinical trials for determining its efficacy as recommended by the FDA. If we look at the drug discovery timeline, it takes really a long time from starting out with candidate compounds, 5,000, 10,000, to really get to one FDA-approved drug. In the other medical fields, this timeline is about 2 years. In Alzheimer's, is much, much longer, especially when we talk about disease modifiers, as we need really long trials in order to see disease-modifying effects. So the very first study of Aducanumab was the phase 1b study. It was a randomized, multi-center, 12-month, double-blind, placebo-controlled trial with 4 drug arms. It was a phase 1b, and it included the placebo arm, 1 milligram per kilogram, 3 milligram per kilogram, 6 milligram per kilogram, and a 10 milligram per kilogram arm. The study invited prodromal Alzheimer's disease and mild dementia patients with an MMSE of 20 to 30, all of whom had a positive amyloid PET scan. And the goals of the study were safety, tolerability, and pharmacodynamic effects, given that it was a phase 1b. So the results from PRIME show that over time, the effect, a gradual dose-dependent effect on amyloid removal became evident. At week 26, we already see some. At week 54, dose dependent with 10 milligram dose, higher than 6, higher than 3. And you can see here on the left panel, on the right panel, I apologize, the effect over time in placebo, 3 milligram, 6 milligram, and 10 milligram per kilogram in removal of amyloid from the brain. The cognitive effect was also there. The primary outcome was CDR sum of boxes, and there was a very similar dose-dependent stage-like improvement or less decline on CDR, I must say, in treated participants relative to placebo. These were very encouraging results. The field was ecstatic. With that, Aducanumab moved to a phase 3 trial. These are two sister studies, studies 301 and 302, also known as Emerge and Engage. They were 18-month-long, randomized, double-blind, worldwide studies. They enrolled 3,285 patients in 20 countries and studied, again, early Alzheimer's disease, defined as MCI due to Alzheimer's or mild Alzheimer's dementia. There were 2 dosing regimens, low and high, and a placebo group. Randomization was 1:1:1. The primary endpoint was CDR sum of boxes at 18 months, and secondaries were MMSE ADAS-Cog13, ADCS-ADL, which is a functional scale, and there were biomarker sub-studies. As luck may have it, there was a pre-planned futility analysis, which unblinded statistician received data up to March of 2017 and conducted their analysis, and they determined that the study was futile, that there is no statistical chance that both trials will, when the data is pooled, would be, the drug would be beneficial. At that time, actually until the results from the futility analysis were announced, this is the percentage of patients that had completed the 18-month duration of the trial. There were about 60% completers in study 301 and a little less than 50% in study 302. This busy table is from the now published randomized phase 3 study, which outlines the cognitive effects that were observed and functional effects that were observed in each trial. In one of the 2 trials, Emerge, there was a significant effect on the primary outcome, CDR sum of boxes with 22% decline, and also on the secondary outcomes. All outcomes were significant. In the Engage study, that was not the case. And here's the visual representation of the data, 22% less decline in the high dose group relative to placebo and Emerge, and non-significant slight worsening in the treated group relative to placebo in the Engage study. And this is the line graph presentation of the same data for those who would like to see that. The effect became significant at 78 weeks. Importantly, there was amyloid removal, just as observed in the PRIME study. There was 71% decrease of amyloid burden from baseline in treated participants, and 59% decrease of amyloid burden in those who were in treatment in the Engage study. Additional analysis were performed where all the study dosage received by participants was plotted. And then what you see here, and that's across PRIME, Emerge, and Engage, as you can see, and what you can see on the x-axis is amyloid PET composite SUVR, so change in amyloid over time. And what you can see on the y-axis is CDR sum of boxes, mean difference from placebo over time. And there is a very nice and persuasive dose-dependent relationship that one can observe with the highest doses, showing the greatest effect on CDR sum of boxes.
The FDA granted an accelerated approval. And what is an accelerated approval? It's really an approval for a serious or life-threatening illness which Alzheimer's is part of now. It was really developed for HIV back in the day and has been used mostly for cancer. And such an illness can be approved based on a surrogate endpoint. So the surrogate endpoint in this case is amyloid deposition in the brain. So there is amyloid removal, and this surrogate endpoint has to be reasonably likely, not required, but reasonably likely to be associated with clinical benefit. So in this case, there is some suggestion of clinical benefit in one of the studies, not in the other. And it's assumed that reducing amyloid will result in improved in disease modification, basically in a clinical benefit for patients. This is the rationale for the FDA to nod favorably and provide this accelerated approval. This accelerated approval is conditional. It would never be a permanent approval unless another post-approval trial is conducted. And that's one of the requirements for Biogen under this particular approval. So serious or life-threatening condition, unmet medical need, surrogate endpoint is allowed, and that endpoint should be reasonably likely to predict clinical benefit. There should be biological plausibility of the relationship between the endpoint and the desired effect, and empirical evidence to support that relationship. Now, the FDA came with the prescribing information, that's their job, and when it came out, that was probably like the biggest problem was that it was so broad. Regardless of how the trial was conducted, this label actually is for the treatment of Alzheimer's disease. So what stage? Preclinical stage? Severe stage? Bedridden? It was not clear in the label. Very little specification about patient selection was made. And this is when Jeff Cummings, again, with a group of key opinion leaders, came up with the appropriate use recommendations. The first article came out in last year, around the summer, and a new article updated with new data from the open label extension and some of the experience of those who have administered to clinical patients. That also is coming out this, if it's not online, it's coming out this week. So let me go over and just really tell you the goals were to translate that package for clinical practitioners and define who should we treat, how should we treat, and how should we manage ARIA. And it's important to know that if we follow the clinical trial inclusion criteria to the T, only a very tiny fraction of all patients with Alzheimer's disease and with MCI would qualify. Basically, these are how many will be excluded based on one or more criteria as the trial was conducted. And this little fraction here is how many would have gotten on treatment. So less than 10% of those with mild dementia and about 15% of those with MCI. And that is not realistic, not acceptable to some extent, because it's too restrictive. So here are how we define the patient population in those two articles. First and foremost, we agree that it should only be administered to patients with MCI due to AD and mild dementia. However, the age range in the trial was 50 to 85. We postulated that this age range could be somewhat broadened under some circumstances. There is no real evidence or logic that patients who are 86 or 48 would not benefit from the drug, but of course, one should be cautious because those age groups were not studied. But we are respecting that, it might be plausibly efficacious if it is, or safe to administer to those participants. Now, the inclusion criteria based on cognition are listed here. CDR sum of boxes. The CDR is a very lengthy scale to administer. So we adapted that to MMSE and MoCA, and you would notice that actually we allow 21 to 30 in our criteria compared to 24 to 30 in the trial, and that's because of statistical appreciation that there is inherent noise in any measure. So this would be 24 of MMSE, could, in test retest, test down to 21 realistically. So we actually adopted the 21 in our recommendations. Positive amyloid PET was required in the trial. We allow also CSF biomarkers consistent with Alzheimer's. APOE genotyping in the initial set of criteria that were published. It was not strongly recommended. Practitioners were advised that it's important, and should the patient want it, they could obtain it. However, with the new data that I'm going to show you, we strongly recommend that the patients are genotyped and counseled about their risks. Non-AD disorders obviously are excluded. We don't specify any specific cardiovascular conditions, but require stable cardiovascular health at the discretion of the treating physician, as well as stable medical conditions, stable psychiatric conditions. Female subjects are excluded both from the trial, and we uphold that recommendation as there is no data. Patients who are with bleeding disorders, anticoagulants should be excluded. Standard of care, so donepezil memantine is allowable. And the pre-treatment MRI, so there's this screening MRI that has to happen, and the safety criteria for allowing somebody to go on Aducanumab is there should be no acute or subacute macrohemorrhages, no more than 4 microhemorrhages, cortical infarction greater than 1.5 centimeters, and 1 lacunar infarction greater than 1.5 centimeter. Technically, lacunar infarctions are always of that size. That would be exclusionary, as it's assumed that these patients are at greater risk. Those with more than 1 area of superficial siderosis and those with diffuse white matter disease are also not eligible. Informed consent was, of course, provided by participants in the trial. In the appropriate use criteria, we don't really recommend informed consent, but clearly there should be a discussion between the physician and patient and care partner and family about the nature of this treatment and the risks involved. What we recommend is to discuss what the requirements are. These are monthly infusions, that there are risks, especially associated with ARIA, and there will be monitoring MRIs and safety checks throughout the titration phase, that there is a possible benefit, that the treatment has shown amyloid removal, but really hasn't convincingly shown a clinical effect yet. So that has to be disclosed to participants, and there is uncertainty about that. And also, very few minorities, so Hispanics or Blacks or Asians, were included in the trial. So one cannot really convincingly state that this drug is safe to administer in these populations. It might be, but if prescribing to minorities, one has to be upfront about the lack of data in their racial, ethnic group. So here is how Aducanumab should be administered: monthly infusions, 10 milligram per kg, and it's there is an escalation every 2 months. So the first 2 months, patient would receive 1 milligram per kg, then 3, then 6, and eventually 10. There are some recommendations if doses are missed, most commonly because of ARIA, to be honest, how to restart at which dose and where to conduct this treatment. So here is the recommended ARIA monitoring, as we recommend in the newest article. Basically, there is this initiation MRI, which is allowable to have it within a year prior to study start, but honestly, it's best to have it within 3-4 months so that there is a concurrent picture of how many microhemorrhages, if any, and strokes and white matter disease, all of that. The exclusionary criteria have to be appreciated. Excuse me. And then, of course, if at any point in time there are symptoms, this is suggestive of ARIA, an MRI should be done right away. If no symptoms, still there should be some screening MRIs, and what we recommend is MRI prior to the 5th dose, the 7th dose, the 9th dose, and the 12th dose. So prior to escalating to 6 milligrams into 10 milligrams, in couple of observations on the 10 milligram dose. And these two that you see now marked with the arrow are in addition to what the trial was doing. So basically they had the screening MRI 7 and 12 dose, safety MRI checkpoints, and we are adding the 5th and the 9th because data shows that ARIA can develop early in the disease course, and of course it can also the later. So here's the radiographic severity. I'm talking to an imager group, so it's probably worthwhile mentioning. Mild ARIA is defined as a single region of edema. So ARIA E, mild ARIA E, is a single region of edema less than 5 centimeters, or a single region between 5 and 10, or multiple regions less than 10. If there is any region greater than 10, that is severe ARIA. ARIA H is defined by microhemorrhages, less than 4 new microhemorrhages, or 1 new area of superficial siderosis. Moderate is 5 to 9 microhemorrhages, or 2 new areas of superficial siderosis, and severe is greater than 10 and greater than 2. So why does how does APOE4 affect risk from ARIA? It's really convincing data as it's plotted here in these Kaplan-Meier survivor curves. These are your homozygotes, so those that carry 2 copies of the APOE haplotype. These are the heterozygotes right here. All right, so 1 copy. This is with any, this is the carrier, so in between homozygotes and heterozygotes, because whoever has 1 or more copies, this is the frequency. And non-carriers is in blue. So essentially, the risk is not existent in non-carriers. It still can occur, but it's much heightened depending on how many copies of the APOE4 variant they carry. The symptoms are headache, confusion, dizziness, and nausea most commonly, although fatigue, blurred vision, other visual impairments, and gait disturbances, as well as seizures, have been reported. The management depends on the severity and the symptoms. So if there is symptomatic ARIA, treatment is suspended. So if there are, any of those symptoms I just mentioned, treatment is suspended, clinical assessment takes place, and repeated monthly MRIs are the checkpoints. And if the MRI shows, actually this trial showed that it's safe to restart patients on therapy even after ARIA. So even after moderate symptomatic ARIA. So if the MRI shows resolution of the edema or stabilization, no new hemorrhages on ARIA H, and the patient wishes to continue, they can go and get titrated back either same dose or a dose lower, depending on how many doses are missed. If the ARIA is asymptomatic, but is severe or moderate, the protocol for symptomatic ARIA needs to be followed. If asymptomatic or mild, treatment can be safely continued, but there should be monthly MRIs for this person. And if no change or ARIA resolves, then it could be continued indefinitely, potentially. So Aducanumab has to be stopped immediately and for good if there is any macrohemorrhage, more than 1 new area of superficial siderosis, more than 10 new microhemorrhages, more than 2 episodes of ARIA, and ARIA can be recurrent. So it could come and resolve, and the patient stays on treatment only to develop, in 10%, it can be recurrent, and they can develop another episode of ARIA. So if there are 2 episodes of ARIA, treatment should be discontinued for good. And obviously, if there is severe ARIA. So here's a few cases. This is a published case from Gil Rabinovich. It's a neurologist who has early onset Alzheimer's. At 65, he was in the mild stages of the disease. And actually, he is homozygote for the APOE4 haplotype. And after the 4th titration dose, so that's 3 milligrams per kilogram, he developed explosive headache, confusion, and alexia. His systolic blood pressure was high. He was admitted to the ICU. There, he stabilized, ARIA stabilized. He was discharged home, but his symptoms worsened, and a repeat MRI showed worsening of his ARIA. So this is his initial 1st dose MRI. And then on January 12th, you can see how he had developed multiple areas of edema, and this definitely is greater than 10 centimeters. So severe ARIA radiographically. He was discharged, and on January 29th with worsening symptoms, he has more edema As you can see, some of the lesions are growing and potentially something is developing here. Then he was treated with, he had seizures as well at that time. In EEG was epileptiforms. He was treated with Keppra and methylprednisolone IV, and then he recovered fully. And by that, we also mean cognitively as measured by MMSE. You see his initial MMSE was 29. He recovered fully, no longer taking Aducanumab for obvious reasons, and has an MMSE, MoCA, I'm sorry, and has, actually he switches. So MoCA was 22 at symptomatic. So MoCA was 22 at symptomatic ARIA positive, and then MoCA was 30 out of 30. But we know MoCA is even more difficult. So with the MoCA 30 out of 30, MMSE is as well 30 out of 30. Now here's a summary of 5 other cases. This gentleman is included in the summary slide. So there are 6 severe cases with APOE4 that were observed during the EMBARK study in Aducanumab open label extension. And all of them are APOE4 positive, all 6. 5 of them are APOE4 homozygotes. And 3 of them actually had 3 or more recurrent episodes of ARIA. This is where the recommendation to stop after 2 recurrent ARIAs comes from. All were hospitalized, 5 received steroids, 1 eventually died. There was 1 macrohemorrhage, 5 of the 6 had seizures, and 3 had status epilepticus. 1 had evidence of cerebral amyloid angiopathy on the baseline MRI. 1 had an underlying autoimmune inflammatory condition, and 3 of those could have been prevented if recurrent ARIA was a stopping criteria at that point. And so this is all the data we have currently, and there are 3 other amyloid-reducing antibodies currently in development, and all of them have received the breakthrough designation from the FDA. Some have submitted data to the FDA for approval, again, accelerated pathway, and these are donanemab, gantenerumab, and lecanemab. All 3 reduce amyloid in the brain, so there's target engagement, just like we saw for aducanumab. So unprecedented times in AD therapeutics. Selection of patient is really important for patient safety, and the decision has to be done not by the physician, but rather by the patient and their family. If this is a good therapy after they're presented with the likelihood of clinical benefit, which is uncertain, and with the side effect profile of the drug. But, you know, in all honesty, this is a very expensive treatment. Biogen came down in price, half the cost, but still it's super expensive. So there would be an incredible demand on the insurance companies. And honestly, most of these are Medicare, so the government insurer in this case. So there would be there is cost associated with that will be passed on to Medicare beneficiaries across the board. So that would be challenging, but also it's challenging for clinicians, healthcare systems, patients, and their families because of the nature of this treatment, how it's administered, and the fact that dementia experts are far and few in between in the United States, and other physicians, neurologists should get educated and hopefully will get comfortable enough to decide to prescribe this therapy, because we really cannot reach everybody who might meet criteria. And with that, I'm thanking you for your attention, and I'm opening for questions.
Thank you, Liana. That was a brilliant overview of what I think is a very important topic. Thank you very much. Are there any questions?
Yes.
So, yeah, Ian has a question.
Hi, thank you so much. That was very interesting. So you used the word incredible, the definition of which is impossible or very difficult to believe. Is that the way you feel about aducanumab?
The way I feel, whether it's credible?
Well, you said it was incredible, the demands it places on the system.
Incredible demands. Yes, that's how I feel about aducanumab. I think, yeah, we're in no way are medical systems ready for, a million of patients with meeting criteria to receive this drug. Their radiologists have to be trained in recognizing ARIA, because sometimes it could be quite subtle, and if it's missed, it could be quite deleterious for the patient. So that would be a great, great pressure on radiologists to learn quickly to recognize ARIA. Then on neurologists, on ICU doctors, yeah, there would be a great pressure on the system. It's not approved by insurance. Medicare has made an announcement in January that their final decision is due in April, which is in a few days. April 11th, I think, is the date by which Medicare has to announce. With the approval of Aducanumab as covered entity, there should be approval for amyloid PET as well, right? A very expensive imaging pathway versus LP as well. There's cost associated. All these safety MRIs that have to happen have to be paid by insurance as well. So imagine what that means. So that is another side of this sort of therapies, all of them, including the 3 that are in front of the FDA. So yeah.
And just a quick follow-up. So you and your co-authors have created a paper describing what you think should be the prerequisites for someone to be put on Aducanumab. Is it as stringent what you just told us as you personally believe it should be? As in, like, everyone who. Sorry, go ahead.
Yeah, everyone should follow these. No, these are recommendations. They're not labeled as criteria. They're labeled as recommendations. So every physician has to do their own clinical judgment and ethically and responsibly administer the drug. So these are our views on how the drug should be administered.
So you would agree that anyone who adhered to your criteria, you think would be a good candidate for the drug?
Not everyone would be safe. So how do you mean everyone? These are guidelines for safe administration, but side effects will still occur. So they're not deterministic. These are guidelines, they're recommendations. And this is how I will practice administration of Aducanumab for certain. But there would always be the disclosure that side effects can occur. There is a risk of lethal hemorrhage even. And there is no way to know in advance which patient will develop and which won't, aside from, the risk that's conveyed by APOE4. I would not make such strong, you're using the words in such a strong deterministic fashion. And I would say these are recommendations, but clinical judgment is always required. And there is always the risk.
Thank you. Thank you so much.
Yeah.
But perhaps I can ask a quick follow-up on something you said in answer to Ian, actually. So you were talking about the need for either amyloid PET or CSF. So I guess kind of implicit in that you don't think that the blood biomarkers of amyloid are yet ready to serve that role?
Well, they need to be approved by the FDA. We have one. There is a blood amyloid test by C2N that is available, FDA approved. It's super expensive as well. So at this point in time, I don't know how much utilization it has across, because insurances haven't yet embraced it quite. Some of the private insurances are paying for it, but it's an expensive test. So I do firmly believe that blood biomarkers are the future, and I am so excited about this development. But yeah, we're not there yet. They're not on the market, but they're coming. They're coming.
Okay, and a somewhat related question, if I may, and then I'll pass to somebody else. But on the topic of kind of having the biomarkers that match the trial's inclusion criteria, obviously with Lilly's Trailblazer-ALZ trial for donanemab, they have tau PET as well. Do you think that the future appropriate use recommendations for donanemab would repeat that need for tau PET?
Well, so their therapy is selected based on tau burden. So individuals with little or no tau are excluded. Individuals with high tau burden are excluded as well. And only those with mild to moderate tau binding are the ones that were administered the drug. And then when they analyze the data, those in the highest tertile, the ones that, or quartile, I can't remember, the ones that have heaviest tau burden benefited the less. So there is that evidence for donanemab. We don't know if it generalizes to other drugs. We can't know until we see the data. But yeah, there is that. So whether it would be maybe plasma tau, I don't know that, you know, tau imaging per se will become a common test to use, and tau in any PET imaging is so expensive, it's rare, patients don't have ready access. So I think the plasma biomarkers actually are going to make those decisions for us, which is quite neat. But also we should understand the behaviors between the plasma biomarkers and the drugs, which I just showed you, that there is decline in p-tau 181 as well, but more data is needed, because that could be another way of seeing treatment efficacy in the individuals based on removal of amyloid, of course, not clinical benefit. That would be a tougher act to prove.
Thank you. I think I saw Mario raise a hand.
Yeah, Liana, can you hear me?
Yes.
Oh, thank you for your great talk. My first question is about the comorbidities in terms of often other neuropathological changes are reported in a subject with AD. So my open question is, do you think that comorbidities can have an impact on the to reduce the effect of Aducanumab on the cognitive performance? For example, I'm thinking TDP-43 or Lewy body.
Well, definitely comorbidities are playing a role in cognitive decline. And there is rarely just pure Alzheimer's disease in cases. There was a beautiful article published that reported about 12% only that have pure Alzheimer's, and everybody else has more than the 2 proteins, has 3 or 4 even proteinopathies in the brain. So they are contributing. They're assumed not to be the driving part of the pathology, but they're contributing. So yes, I mean, we're not going to be removing anything but amyloid from the brain. So those proteins will still have some effect, but also we're not expecting an improvement, cognitive improvement. There will be slowing disease progression, halting disease progression, but not cognitive improvement. So nobody is ever going to go back to baseline. This is not a cure. This is a disease, hopefully, we don't know, but hopefully a disease modifying therapy. So yeah, there would be no effect on TDP-43, on argyrophilic brain disease, or anything of that sort.
Yeah, thank you. I have a very quick question about Aducanumab and every kind of drug increases significantly the medical cost for each subject. Do you think that the drug costs represent one of the many limitations for developing a good AD treatment?
The cost? No, I think pharmaceutical companies know that, you know, Alzheimer's is so common that it's a good disease to find the cure for.
Yeah.
From a business perspective, I don't think that's holding them back, to be honest. But well, some close their Alzheimer's development pipelines, of course, but that's a business decision, of course, they made. But there are still those that are actively pursuing multiple avenues, including anti-tau treatment, anti-inflammatory, vaccinations. Yeah, I think this is an ongoing race to finding a good drug for all.
I was thinking the combination of these different treatment and different biomarkers to characterize the patients, if it becomes too expensive for each one.
Yeah.
State of the art.
Yeah, well, if we are able to diagnose early in the MCI stage and slow disease progression, there would be that benefit of, you know, of reducing disease burden on the healthcare system. So ultimately, there could be savings from being able to influence disease course, but of course, that has to be proven in the future.
Thank you. Thank you.
No problem.
Yeah, I had a question, if I can. So I was just I was thinking back to the original trials and the difference in the high dose regimes. I was wondering what the current sort of thoughts are, if there's any reasons why that is, that there's such a big difference between those two groups now looking back at the data. I was wondering whether there's sort of different incidence of ARIA between the two groups, for instance, that might indicate that they respond indifferently for other reasons.
Well, I think it's all about what the good therapeutic dose is. I think these trials are developed to find the dose that has the minimum side effects, but it's effective, right? So the 10 milligram per kilogram is the one that has proven to have statistically significant effect at this point in one of the two trials. So it's drug development. You have to find an effective dose. I mean, too little is not going to help. Too much is going to cause too many side effects. So there is the holy grail right in the middle, which is the one that they're pursuing.
Yeah, but I was just wondering, because they're both high doses, had a different response. So I was just wondering if there's what the current thoughts are around why that was. So the high dose worked in one, but not the other.
Why do you say that? Let's see if I can reshare.
Maybe I'll get to the end of that.
Yeah, we can go back. Getting there. So basically, this is mean SUVR. So removal of amyloid, low and high dose both work. So there is the target engagement. It's not like that one doesn't, just the high dose removes better.
I think I was thinking of one of your previous slides where you showed the actual effect on cognition, I think. One of the first, first slides you showed. Yeah.
Yeah, here it is. So both didn't work here, not statistically significant from placebo. In this trial, there was dose effect. So looks like the lower dose also has some effect, but it's not significant. So it can be. So I don't know.
Okay.
Is this what you meant?
I was just wondering why, because I was wondering if there was any thoughts now on the difference between the two, the emerge and engage, and why they got different results. The difference in the people involved, the cohorts, whether people had looked at the data to try to explain the differences, the different results.
There is always explanations, and one has to be careful in over-interpreting. What Biogen is stating as plausible explanations is that fewer people in the ENGAGE study actually there was a protocol changes along the course of the trial. There were 5 modifications, and higher dose was administered to a greater number of people in the EMERGE trial compared to ENGAGE is one of the plausible explanations. So again, neither trial was fully enrolled and fully powered, so hard to know. And that's why there is the requirement for Biogen to do another trial, right?
Okay, yeah.
Okay, I think we maybe just have time for one more question. I think Demetria raised a hand.
Hello. Thank you for your talk. My question is, how likely do you think it will be to develop and combine anti-amyloid and anti-tau treatments in the future? Thanks.
Well, we know that it takes decades to go from screening compounds to a successful drug. Currently, we have anti-tau therapies in trials. Lilly announced that their monoclonal antibody is not going to be carried forward because it didn't show the expected efficacy in their preliminary studies, but they have others that are being developed. The OBA inhibitors and other monoclonals are being developed by other companies. So we're looking at a few years before we know the readout on some of those. We're looking at readouts from Sulonazumab, which was the first Lilly drug that was not successful in MCI and mild AD, but it's currently being given in preclinical stages in the A4 study. That trial should read out by the end of the year. We might have results, and it's exciting times are coming. We'll know more first about the anti-amyloid and then the tau therapies.
Okay, any other very quick last questions from anyone? No, okay, well, I think we're at the end of the hour anyway. Thank you again, Liana. That was a great talk and great Q&A. Thank you for answering our questions. It's been great to have you here.
Thank you for having me. All the best.